The other thing that certainly you've been very passionate about, and we've had several discussions, and we've been tuning some stuff in protocols, since you've been with UH, are the combative patients and the excited delirium cases. And I guess let's start with that whole nomenclature of excited delirium, because I know that's kind of contentious, and there's a constellation of symptomology there, and it's recognized and defined in some places but not in others, and maybe it's time to kind of start tuning some of that nomenclature, maybe keep ourselves out of some legal trouble, or certainly clean up some charting.
Yeah, so excited delirium, unfortunately there are certain physician groups and medical groups out there who don't believe that excited delirium is a syndrome. And we've all seen patients who are profoundly agitated that would kind of be consistent with that. But the new nomenclature that we're supposed to be using is hyperactive delirium with severe agitation, which is a mouthful, and it's much harder to say.
I got it.
I have to look it up half the times before I say it. But it's the same kind of idea, where this patient is so profoundly agitated that they are clearly of imminent danger to self and danger to all those around them. There is no talking to them. They are running around. They're like bench pressing individual people with each arm like it's not even a big thing for them. And the reason it's so concerning is they are at a hypermetabolic state. They're developing, releasing lactate, they're releasing potassium, and they are at imminent risk of cardiovascular collapse. And if we don't intervene aggressively, they could suddenly drop dead right in front of us. And oftentimes, it's the delay in sedating them and kind of getting control of the situation that is most harmful to these patients.
I think back in my career, and I've had a couple of those, and one in particular stands out. We rolled up on a guy, and he was just beating the hell out of a RTA bus stop. I mean, of course now he's all cut up, he's covered in glass, he's covered in blood. There were 8-10 cops on top of him, and he'd just throwing him off left and right, like they weren't even there, right? And essentially, that exact scenario played out and then this was in the days before we had ketamine. We had these faster acting agents. Matter of fact, Versed wasn't even on the truck at this point, right? Our option was restraint and maybe some Valium, but we know that works very slowly, if at all, intermuscularly. We weren't going to.
You can't get IVs on these patients. They're too agitated.
They're bonkers, right? So we basically laid on this guy, tried to tie him down with everything we had at the time, which was Curlax, right? I guess that does bring up a little side pet peeve of mine. Get purpose-made restraints. That really bugs me when I see people come in, tied down with this day and age, right?
I agree. Commercial device. It's safer for the patient. Right, it's
designed for that.
It's designed for that. It's going to protect them. It's padded for that reason, right? There's that whole stigma around, and we're going to talk about it. Use of ketamine for chemical restraint, and then we talk about physical restraint. Do it the right way, in the safe way, and then it's better for the patient, right? Because it is a true emergency to them. And I agree wholeheartedly. Buy, the Posies or whatever they call them, the name brand or whatever. So it's padded. It's a quick release. The same thing with the part that loops and is going to attach to your cot. It's just safer for them. It's safer for the whole environment. So if something changes, and of course we want to restrain that patient the correct way, right? So supine, elevate their head at 30 degrees, one arm up, one arm down.
All four extremities.
All four extremities, stuff like that. Take into account, but I agree 100%. In this day and age, there should be no cravats or cling or any of that crap. No, there should be commercial device. It's affordable. There's no reason to not have it. I agree wholeheartedly.
And they need both restraint and chemical sedation. You don't do one without the other. Correct. Because it's not gonna work effectively.
No, and it's not humane too, because
they're still struggling.
They're still gonna fight. They're still in that hyperactive state, and it's just like I think it was Dr. Spanner brought it up. That's that patient. If you had a side mount cot that is just going to slam their head off, now your cabinet there, they're still going to try to harm themselves. They're still going to fight, right? And that's not good for their body. They're still going to be tachypnic. They're still going to be tachycardic. We're still not treating the underlying medical issue that we have here.
And that's the thing is, most of the time it's going to end up being a drug toxicity where they overdosed on a stimulant or took too much of that. But the thing is, there's a lot of medical things that could be going on. They could be a trauma patient who smacked their head and have an epidural hematoma. And the reason that they're agitated is they're about to herniate and die, and their brain doesn't know what else to do. Or they could have thyroid storm, or they could have mania, or like it could just be profound psychosis from their underlying schizophrenia. I mean, it could be any number of things, all of which in themselves are medical emergencies that need to be addressed. But now they have this profound agitation, which is another medical emergency, which we need to aggressively treat.
So that kind of brings up a point: is how do you think we should best navigate whether it is medical psychiatric cause? It sounds like we start with the sedative, right? Basically, in all these cases. When do we get into, or what should, in your mind, are trigger points for, hey, this is mania, this is psychosis, this is a underlying psychiatric condition, and then we add in the psychotropics, the Haldols, or.
So at first, it doesn't matter. At first, you have a profoundly agitated patient, and you have to control the situation so that you provide safety to yourself, and more importantly, you provide safety to the patient, and allows you to assess them to figure out what else is going on. You can't get a good history from friends and family when the patient is acting this way. Like, you have to control the situation, and then you can kind of do all the normal things you do to monitor them. Get an EKG, check a glucose, look for signs of trauma, talk to bystanders to get a better history. And then when you narrow it down, all the things, all the monitors. Like, this is a critically ill patient. They get everything. And if you can narrow your differential down to something like, oh, they have a history of psychosis and they're off their meds, then I would consider adding a little bit of Haldol. But if you've already controlled the situation, they're sedated, they're calm with whatever you led with, whether it be a benzo or ended up being ketamine, you don't necessarily need to add something else. The hospital can get more information and then determine the appropriate longer-acting medication for what is going on with that patient.
So, and we're coming at this currently from the borderline violent, certainly combative case, and we know from previous episodes that when we have that violent case and we've differentiated combative from violence, that our go-to currently is ketamine. But let's talk about the patient that is hearing things, seeing things. They have these psychosis, and they just want help, right?
And that's a key point right there, that they want the help.
They want
They're
help.
not. They're maybe a little bit agitated, but you can talk to them. You can converse with them and get that history.
Yeah. Reason.
So those are the people I would give a antipsychotic to. You can give them an injection of Haldol or an IV dose of Haldol, or you can give them oral Zyprexa, olanzapine, because that's nice because it's an oral dissolvable tablet, and that'll work effectively too. You don't need immediate control of the situation. You're just trying to treat their underlying issue and provide them with some stabilization so that they don't become agitated if their psychosis worsens.
Yeah, and that's mainly en route to the hospital, So it's a patient you might be able to reason with, probably called, or maybe a family member called, hey, you should get help. We can have some type of a conversation. They're calm. They're not trying to hurt you. And a lot of those patients you are able to reason with, get them in the ambulance, go to the hospital. But the point that you made there I like is you want them to not become agitated for the trip, right? And that I think that Zyprexa, especially with like manic schizophrenic, that's maybe off their meds or doesn't have access to them or hasn't, maybe they don't have a route to afford that medication. I don't know, whatever the cause may be. We do have that little tool in the toolbox where it's not invasive, it's easy. It's an ODT, going to pop in their mouth, 10 milligrams, not to be confused with
olanzapine to
ondansetron, right? Or Zofran, because they look very similar in the ODT form. So the Zyprexa in our protocol should be in a clear plastic bag with a bright green label that says this is Zyprexa. Fun note that Zyprexa does give you a little antiemetic effect as well, because we did have a
most
wrong
of the
dose,
antipsychotics
a medical error with that.
Very closely related.
Yeah, but we've set measures to try to prevent that. But I agree 100%. There's a tool there in the toolbox, as Caleb would say, and if they want help, you want to take care of them and get them access to that care. And ours is short-term care, and that's what we need to understand. Ours is short-term care, but we're transporting them to hopefully get access to that longer term.
Right. You have to remember, especially today's day and age, short-term care may actually be somewhat of a long-term care. I'm not sure how many patients he has waiting to be seen. and how many traumas that are coming, or heart problems that are coming.
How
so this
are
patient
shiny
who
objects,
is
right.
olanzapine has gotten it and they're okay. Well, that was an hour and a half ago. So we have to be careful there too. Our handoff is just as good as
That's true. And that's a valid point. You come into a busy emergency room. We talked about trauma patients, and obviously every patient deserves 100% dedication and care. But obviously, we know some are going to take a higher priority because maybe they
simple
are
triage.
Yeah, maybe they're profusely bleeding or something, and then there is that patient is going to wait to be seen versus the trauma patient 100%. So I think.
And I know that we've all been on the call that somebody has called 911 because they know that they're going to get priority treatment because they've been in the ambulance. It doesn't work that way. So there are such a thing as triage.
Priority escort to the waiting room.
Yes.
Yeah. So again, this day and age, I guess we know better. So and that whole olanzapine. Betty and I had a colleague had exactly that case. He had a patient that had a bunch of visual hallucinations. Guy was a little agitated, but he just wanted help. He just help me fix this. And he's like, I have something. Do you want it? He's like, absolutely.
Right.
And by the time they got to the hospital, he's like, I feel I'm not seeing things anymore because he would see people in the room that he knew weren't. He was cognizant of the fact that they weren't there and just wanted the help. And it's like face slam dunk. It's spot on treatment there. And in that particular case. They did not get a benzo. It was just monotherapy with the
which is very reasonable in that situation.
In that particular case, yeah. The guy was a little bit agitated, but you could reason with him. So it was a perfect play there. So now we talked about we talked about the use of restraints from our perspective. What about the already restrained patient, i.e., the handcuffed patient? This starts to escalate our problems in numerous realms here.
So the handcuffed patient is not ideal. One, we can't take the handcuffs off ourselves if an emergency were to arise. I mean, if we're sedating these patients, the thing we're most worried about is loss of airway, and if we need to reposition them or do something, it's much harder. So if the patient comes with you in handcuffs because law enforcement is refusing to take off handcuffs, the things that you need to kind of put your foot down and say is, you have to come with me to be able to unlock the handcuffs if need be. And the patient cannot be handcuffed behind with the hands behind their back or with them in the prone position, because we want to make sure that their ventilation is as normal and least restricted as possible. And we can say, like, hey, if you can take off the handcuffs, we can still restrain them with our commercial device, and we feel comfortable with that. They have to take off the handcuffs. We can't do it for them.
And I think that's usually an easy trade-off, too.
Yeah.
I think you have a great point, Doc. Our police agency we work with is really good. They know that rule. But a lot of times I think we put them in the ambulance. It gets them away from any type of spectators, and then the officer gets in, and then we might transition from their handcuffs to our restraints. It's in a safe environment. Usually they're calmer. Hey, we're going to switch to
You've already sedated them with something.
Yeah, you've already sedated them, and then they can come off immediately.
Okay.
And it's a good thing for, I don't know, maybe it's a small tidbit for providers to think about too. You might be able to transition that. You're in that now, but go into your safe space, go into the ambulance. Because that person that might have been hyperactive that's looking around, now there's drawing a crowd of people if you're in a public setting. That's not good for them. That's not a good setting for them.
It's not good for us either.
It's not.
Our comfortability is the back of the ambulance. That's where I want to be.
There.
That's where I live.
Yeah.
It brings up another good point of sometimes you can do all the nonverbal and not you get the patient out of a certain situation, may calm them down, de-escalate them verbally. If certain family members are riling them up, get them away. If certain family members are helping them, kind of bring them in closer to talk to the patient, but just kind of try to de-escalate before you need to restrain somebody.
Yeah, I agree 100%. You can't pick your family, so.
That's true.
But utilize all your resources.
Yeah,
100%.
In all honesty, I think 80% of those calls I've been on have been able to be verbally talked down. And,
right.
All right, for the best, we're going to the hospital, and then eventually you get to that point where they're comfortable with the ride. So.
Yeah.
That also takes patience on our end. We need to be patient advocates. This is part of our job.
Right.
So.
Yeah, you got to build a rapport with them, talk to them.
And they might cling to him as opposed to me just because
100%.
He smells better,
Yeah.
And you might have one of those little trigger things that just might be the way it is. Don't take offense to it. Drive. I'd rather drive anyways, right? Not me, but
I'd rather.
The goal is get the patient safely to the hospital, and if you can do it with just talking them off the cliff, then that's great.
Yeah, and I think there's that whole stigma as oh, they're violent, I just need to give them a med. Not necessarily true.
Exactly.
Like there's, I don't know. I take a different approach to that. We just had a violent call. We responded to it. The patient did not take to me. They took actually very well to the EMT I was working with, who's a nursing student.
So be it.
And you know what? I was almost out of the room. And then he walked up to me, we're good to go. Okay. Walked the patient to the EMS,
Great.
went to the hospital. There was no need for medications. There was no need to get riled up. I actually kept the police officer outside. I was like, no, we're actually really going really
And
good.
that might be their trigger,
Yeah, I don't want that as a trigger, right? So the person I was working with, it fit, it worked, But I mean, we do have those patients on the other end of the spectrum that are violent, like, Scott, you said, that are going to throw 4 or 5 police officers around. They could injure them. They're going to injure us. They could potentially injure staff in the emergency room too. It's just,
and those
you
are
have
the
to
patients,
change gears.
Those are the patients you're not going to be able to, when it's immediately obvious that they are of imminent harm to self or others, do not take the time to talk to them. You need to get control of the situation. But for the patients who you think you could talk to, take that opportunity.
Yeah, 100%.
Crawl, walk, run.
Let me ask you a crazy question, and I'm not sure your guys' thoughts on this, but I've come recently into a situation where my agitated patient was mostly agitated that I was wearing a face covering. Do you ever see anywhere in this EMS field, hospital system, that we might lift that mandate someday?
I'm not sure. At least in the near future, I don't think so. We have to wear masks to protect our patients, and they need to wear masks to protect us just because COVID is still around. But this may be a long-term thing. It may never go away.
And that's kind of the way I've been teaching it, is that just expect this to stay with us. Because, I mean, you see ORs wearing masks, this healthcare.
Always have. Right?
And they always have. I mean, so that just welcome to the new age of healthcare. I mean, you think about it, why haven't we? And there's really no good explanation as to why we haven't been anyways.
Yeah.
So just curious, because that's been brought up almost every time I teach a con ed recently is, hey, were they going to lift this? I don't see it happening.
No, I don't either.
No, especially as we get through summer, and then we're gonna go into fall, and then it's gonna start even more of a respiratory season. RSV with the little ones is gonna start. We're gonna get into flu again, and it's just.
What are you talking about? Flu went away when COVID came.
Yeah.
But that was one of the benefits of everyone wearing masks is the flu season was very mild,
almost
non-existent.
Yeah.
Which just shows that good hand hygiene and face covering can really make a big difference. The only other thing to kind of discuss, which we haven't hit, is why are we even allowed to sedate people against their will? So if somebody is profoundly agitated, they're not asking us for help. Other people are calling for them. So why are we allowed to restrain them and bring them to the hospital?
Is that a question? No.
That was a question. I was see if you guys had the answer.
He's like looking at me and you real quick.
I'm
going
to go because they're lacking capacity.
Exactly, and that's true not just for the agitated patient, but any one of our patients who we're treating against their will. If they have medical decision-making capacity, which means they are able to reason through their options and make a decision that's based on their own personal beliefs, it doesn't matter if we agree with it, but if they can make that decision, then they have capacity. But these patients, I mean, if you can't even talk to them, they clearly don't have capacity.
And I think the powers to be that write the protocols made that a very easy algorithm to follow, I think, 2 updates ago.
I think it's been 2. I think you're spot on,
Yeah, I think it was 2 updates ago that you guys came up with a very, very easy to follow. How do we determine capacity? Well, it's
all of those questions that that he was alluding to there are essentially spelled out, and here's how to present them.
Exactly.
Yeah.
But it's not getting. And when I QC quite a bit of the charts out there, I don't see it documented the way it should be, and I think that's something that needs to. Eventually, I think we're going to talk on documentation as a whole episode. Probably, I hope it's one of my passion.
No, it's
things.
coming. Yeah.
But I don't see it documented as it should be, and I think that's a huge part of it.
Well, I mean,
because very frequently I see people say the patient was alert and oriented. They have, or they say patient is alert and oriented. I allowed them to refuse. But alert and oriented, you could be alert and oriented and not have capacity, and you could have a certain degree of disorientation and have capacity. It really just you have to have a full discussion, and the truth is, it's a medical legal risk to not document that well in our patient care record. I mean, we really need to say, I believe the patient has capacity or lacks capacity because of X, Y, and Z. And because of that, I did what I believed was in the best interest of the patient, which was X, Y, and Z.
to your point, when I have seen people document it, it's, patient has capacity, patient doesn't have capacity, and then none of that follow on.
Yeah, exactly.
None of
There's
that,
no
none of
rational
that,
reason as to what
yeah.
capacity are we missing here.
Correct.
It's better that they at least wrote that. I see a lot of people not even say the
Not even
words
touch it.
medical decision-making capacity, but you're right. You really need to say that they do or do not and why you believe that. Because if we leave a patient on scene who does not have capacity, that's abandonment. We don't want to do that. If we take someone to the hospital and sedate them to get them to the hospital when they do have capacity, that's like kidnapping and like battery in that case. And,
Correct.
and that's just as bad. And so we want to make sure that we get it right.
And one of the things nursing homes hate that we say is, I cannot kidnap this patient. They have a mental capacity. It's been proven to me.
Mm-hmm.
They need to go. The doctor said they need to go. I can't take them.
Right.
They don't
I'm
want
sorry.
to.
We agree.
They don't
He
want
should go. But he does not want to go.
Yeah.
And that's a fight I will, as a patient advocate, I will fight for the
Mm-hmm.
patient. I will not kidnap you. So, but it needs to be documented, especially in that case, coming from a healthcare facility and us refusing a transport based on the patient advocacy. I need to document that, and
Right.
it needs to be very well documented. So,
Kind of piggyback off of that too is like POA type of
those
things.
get hard.
Those get real. It gets real muddy if the patient that is alert and oriented times 4 has capacity in a sound mind, totally understands. I am their POA. You will take that.
But when does
and
the
I
POA
ran in-
kick in?
But when does the POA kick in? Most
when
of
they
them
lack capacity.
Exactly.
Read it.
Exactly.
when they lack.
And actually,
capacity.
Scott and I just talked about this earlier today. I had this call. It wasn't a psychiatric call by any means, but the patient was a TBI patient, and family had a DNR for the patient, but refused to honor it and was now POA and wanted me to do everything possible for the patient, and that's what I had to do.
Yeah.
But again, going back to advocacy, I have to honor those wishes, but at the same time, it's hard to fight that fight when the patient, their wishes.
Yeah, that's very difficult, and that's a gray area. No one would fault you for being like, I see that this was just recently signed. It's very well documented. It's clear the patient didn't want this. And if you can have a discussion with the family and the family says, yeah, I know the patient doesn't want to be resuscitated, but I want them resuscitated, then you can kind of be like, well, you clearly just said you know what the patient wanted, and we're gonna respect that person's wishes.
But again, a great opportunity to call command.
Exactly.
So.
I would involve command in all those because that's a difficult situation socially.
Yeah. Or if you need guidance and your patient has capacity, but you still think they're very sick and they need to go to the hospital, access to the medical director, make a phone call.
Someone else to talk to the patient. I mean, we may not say anything different, but sometimes they hear that the doctor wants them to go, and that's enough, even though you spelled it out perfectly.
Oh, yeah, 100%. It's just another tool to try to utilize.
And I've also been in the situation, and it's not great, and it happens, though, that where I've had my med command talk to their med command to be my advocate at this point, because I'm doing what's right for the patient.
Right.
I'm the eyes and ears to my med command, and he's going to talk to you now, or she, and she'll make this right. But that is always an option too. And I've had med command talk to the family for me, to the patient, and it just paints a better picture. So just being patient advocates is what we need to be, and involving their doctor essentially, which was going to be the med command for us at that moment, is not going to hurt.
Very true.
The other thing that you were talking about, charting these, doing your PCRs and whatnot. I think it's been the last 2 weeks. The term competent made its way into a chart, and of course we sent that back, and QA is like, hey, what you're really assessing here is capacity, not competence. And they're like, well, I was taught competence. I think we were all taught competence. That's certainly, from an EMS standpoint, to the point it's. I went back and looked at my EMT book, right, and
Competent.
Sure as shit. The whole piece of that was competence, and competence and capacity are not the same thing, right? We can't determine competence.
Competence is a legal term determined by a judge.
By a judge, yeah, and we don't determine that, right? So that was, my challenge to that. In that particular case, was an EMT, and I said, you had legal paperwork from a judge saying this patient was incompetent. Well, no, this is my assessment. That's capacity assessment,
right?
And it just needs to be reiterated that those are not interchangeable terms.
The language is important.
Vastly different.
Yeah, no, that's
they
a
are
great
vastly different things, and we need to be spot on when we document those things.
Well, and especially if we're taking somebody against their will.
Yeah, well, absolutely.
There's also something that hasn't, I think we talked on last time, but we also need to be documenting enrichment, agitation, sedation, pre and post sedation.
I thought you wanted to get into pink slips, and I was just going to strangle you with this cord.
No.
I don't have the energy for the pink slip discussion today.
No, we need to be using a RAS score for anybody
We give you
that
a
we're doing
tool,
this with.
right? We give you a tool,
and it's in the protocol book, so we need to be competent with it.
Yeah,
it's easy. It's really easy.
Yeah.
It just supports your use of ketamine if you decide to use it. It shows that you
Or
believe the
any
patient was that agitated they needed ketamine, or wasn't agitated enough for ketamine, so you elected for Versed.
Yeah.
But yeah, and I think there is the misunderstanding. I don't know if we touched on this or not. It's like that needs to be done prior to that decision making. You know, it's a justification,
right?
And then that's why it's there.
Yeah, pre and post. That's the reason it's
say,
there.
Now
let's talk pink slip.
Let's not. Let's not. That's probably an episode all in and of itself.
Or three.
And we're in the process of tweaking that. So until that sees the light of day, let's sidestep that. Any other big points for the combative and the restrained patient? I think we hit a lot of really good ones.
I agree.
I think positional is just one of my biggest takeaway points. You know, I can't remember who just had an article, and it was on positional asphyxiation. I want to say it was GEMS, or it was one of the medical journals.
EMS 1, I think. Wasn't it?
Maybe it was EMS 1. It was an article that posted about it and just the importance of doing it, you know, the right way. And we talk about restraint, proper procedure, utilization of, you know, chemical restraint, physical restraint. We talk about the proper way to do it. We put a picture in the protocol for you. This is how you're supposed to do it. We have the RAS score. We need to determine whether or not this patient has capacity or not. Like, we are building all the points that you should be documenting in your chart, why you did what you did, so we can take a lot of that stigma away from, we gave them ketamine too, right? There's always that circling around the room. We talked about that a lot with Dr. Spanner. And, you know, if these drugs are used properly and in the best interest of the patient, because they were true, agitated, or in their hyperactive state where we're just unable to protect them or us, you know, that's why they were utilized. And we need to position them the right way. We need to follow these items that we've set in place, right? It's for safety of the patient. It's for safety of the providers. I think if it's done right, then it's a safe transport to the hospital and to a higher level of care that's hopefully going to help them maybe long term.
We're not sedating patients to facilitate arrest. We're sedating
Correct.
patients because they're having an acute medical emergency. If the police happen to call us to say, I believe that this patient is very agitated and has an acute medical emergency, which is why they're calling us to the scene, we have the right to treat them if they do not have capacity. And these patients often do not. And so we're not just sedating them and just handing them over to the police saying you can go to jail now. We are bringing them to the hospital under the highest level of monitoring to make sure that they get good critical care and good resources.
I agree, 100%. And all the safety measures are there from the medical director standpoint, the QA standpoint we talk about. You know, it's just, we closely monitor that to make sure we're doing what's best for the patient. Mm-hmm. I agree 100%.
Police can come back and pick them up from the hospital.
If they decide to later. But
Yeah,
that's second to patient care.
It's
Exactly.
secondary, yep.
Yeah.
It's absolutely secondary.
The only other things that I would bring up is that like a simple way of kind of figuring out how to sedate the patient would be if they're profoundly agitated, that the new term, hyperactive delirium with severe agitation, they need ketamine. They have a ketamine deficiency, get it to them as soon as possible. If they're just a little bit agitated, you can give them Versed or another benzo. And then if there is obvious signs of psychosis or they just are a little bit psychotic and are asking for something, then give them either Haldol or Olanzapine, whatever you have access to. And that's how I'd recommend sedating patients. And sometimes you may give them ketamine and they may need something else. If you give them the full dose of ketamine as per our protocol, then I would call command and say, hey, this patient is still agitated. What else can I give? And in that case, I'd say give some Versed in addition to the ketamine. But you need a command order for that in our system.
Excellent.
Anything else for that? I think we hit most everything.
One last thing.
Oh, sure.
When you do sedate the patient, they absolutely need all the monitors, like end-tidal CO2, cardiac monitor, glucose, get a 12 lead, do everything. Spare nothing because, one, we don't know why they're so agitated, and two, we want to monitor them because they're critically ill.
Yeah.
Yeah.
Cast a wide net.
Exactly.
Yeah. Let's not miss anything. Yeah, and all of it's non-invasive. It's not
Exactly.
It's not like we're asking you to do incredibly difficult things. It's just clipping things on.
That's bread and butter.
It is.